You still have to be a doctor. You still have to give your own clinical judgment. But comprehensive exams are so challenging because we have so much breadth of information we need to evaluate the patient for, that if we don't try to define what that comprehensive exam is looking for, and when something is abnormal, we actually take a step back and say, this is abnormal. This does not fall in line with our normals, which means that we've got to evaluate this patient more. And the whole idea then is that if we do that, we will have more confidence in our conversations with the patient. The patient will perceive the importance and the critical nature of what you're finding and why you need to, it's in their best interest to evaluate that. And long term, those patients, when you follow them and you find glaucoma early, even if this patient was normal and you follow a specific protocol and you've drawn those lines in the sand, the likelihood that you're going to miss patients that are walking around with glaucoma that you didn't identify is going to be minimized. So you're absolutely helping your patient population. Hello and welcome to the Chris Wolfe Podcast on iCode Media. Today I want to talk about step 2. When we talked last week about building a pillar, we talked about forming patient questionnaires, whether they're verbal or written. And making the questions so important to you that you're minimizing the gray in how you're going to act. So it's so important to you that you have to act. That's what's really important in step 1. Today, we're going to talk about step 2. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education, for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com. Hello, dedicated optometrists. Are you looking for a way to support your patient's vision and overall eye health? Let me introduce you to Vision Edge Pro, a visual performance supplement that stands out in our profession. Vision Edge Pro contains a balanced blend of mesozeaxanthine, lutein, and zeaxanthine in a 10-10-2 ratio. This combination has been scientifically shown to increase macular pigment density, which enhances visual performance, including contrast sensitivity and vision in glare situations. Additionally, Vision Edge Pro provides 300 milligrams of DHA and EPA, fulfilling the daily requirements for omega-3s as recognized by the leading health organizations. This ensures your patients receive the essential nutrients their eyes need for optimal health. Whether it's for everyday screen use, night driving, or enjoying the outdoors, Vision Edge Pro supports your patients in seeing their best. Recommend Vision Edge Pro for your patients today and help them achieve clearer, healthier vision. Contact your local Macu Health representative for more details. Vision Edge Pro, because your patients deserve the best in eye health. Go to macuhealth.com and use the coupon code podcast2024 at checkout for special discounts. Okay, so when I think about designing a clinical protocol, the next step is you've already created, remember, we have started with saying, look, these questions that we're going to ask the patients, they have to be so important to us. The answers to those questions have to be so important to us that we have to act. We have to actually take them seriously. So one of the things, I'll try to give you some other examples of things that are no-brainers in an optometrist's mind about whether they're going to act. So let's say on your normal exam form or your normal entrance form that the patient might fill out, we use the example of flashes and floaters last week. So if a patient has acute flashes that they're coming into your office, you already know immediately, how am I going to direct this evaluation for the patient? And there's no real gray area there. You're not saying, well, maybe I'll address it if the flashes are really bad, or I might not address it if the flashes are just they happened one time yesterday. Probably that finding or that symptom is going to be so powerful that you will absolutely act. Now, that's a very clear distinction. What if you had a patient that has sudden vision loss? So sudden vision loss, you're not going to say, if the patient says, I've got sudden vision loss that happened in my right eye yesterday, your evaluation of that patient is going to absolutely dive deep into that symptom. But with other symptoms, the challenge is that if they're really varied, or if we don't put as much emphasis into how important we think that question is, then we can sort of wave in the wind, right? And that was the goal of last week, is to make less wavering, because the questions we're asking are so important to you, so that the answers from the patient are going to force you to act, minimizing the gray area. So that's the one of the biggest parts of building a pillar. The next biggest part is, what are the clinical findings that I see related to a specific disease state that are so important to me that when I see this, I have to act, right? I have to have a conversation. I have to have some additional evaluation for the patient. I have to have some sort of treatment for the patient that I can't ignore. And the reason that's important is that when you get busy in your schedule, one, it can be easy for you to just sort of overlook some things that might otherwise really be important to you. Especially if those things are important, but they may not be critical or emergent. So if they're maybe more chronic in nature and not likely to cause a patient a real problem in the next 6 to 12 months, then it can be easy to just kind of put it on the back burner and get to what that patient is ultimately, or maybe their chief complaint is there to address. So, I think about that as like, all right, well, the second reason that it's important, not just to get you to act, but the second reason it's important is so that you're consciously aware of the things that you think are important during a comprehensive eye exam. And again, that's critical, because if you get busy or you get behind, you can kind of move through your eye exam looking for really obvious things, but subtle things can escape you. And this happens to all clinicians. And so you've got to kind of draw a line in the sand to say, if I see this, I'm going to act. So again, one of the things I love to use is dry eye and meibomian gland dysfunction. I know people probably are tired of hearing about it, but when I look at a patient for a comprehensive exam, when I think about their risk for problems associated with dry eye, largely that's going to be early, or I will detect it way sooner if I look at the eyelid margin. So when I do a clinical exam, I always think of my mentor, Bob Vandervoort, who's in the back of my head saying, Chris, don't be a peruser. Don't just kind of peruse along the lid margin and peruse over the cornea. Take an active approach. So when I think about the lid margin, if I were going to design a protocol related to dry eye and identifying dry eye and meibomian gland dysfunction in my patient population, then I would pay a ton of attention to the eyelid margin. And the things I would be consciously looking for every single time I'm doing a clinical examination would be cap meibomian glands, saponification, telangiectatic vessels, and then I would look for some sort of secretion. Now, you might not think all those things are critical, but for me, if I see positive findings on any of those things, when I pull the slit lamp away and I have a conversation with a patient and I address their chief complaint, which might be completely unrelated, I'm also going to be forced to act, because I think those things are so important to that patient's longevity for comfortable, clear vision, that if I don't act now, at some point in the future, it's going to cause that patient a problem. So the point is I can tell you those things for all of the chronic diseases: my macular degeneration, glaucoma, dry eye, meibomian gland dysfunction, allergies, anterior segment diseases like Fuchs or anterior basement membrane dystrophy. So those are kind of very common chronic diseases, diabetes. And so I can talk to you about what's important for me, but what's really important, what we help practices all the time, is customize that for themselves. So the reason is that if I tell you what you should be doing, you don't own it. And so it's not part of your identity. But if you actually believe that what you put down on paper is so important that you will have to act, and what I mean by that is have a conversation, integrate some treatment, have a follow-up with the patient, whatever you, again, that's in future steps, but whatever you deem appropriate, you will absolutely do it. You can't turn away from it. CooperVision and the AOA have joined forces in a groundbreaking initiative to transform how optometrists treat children with myopia. The Myopia Collective aims to unite our profession and its allies to challenge the status quo and elevate the standard of care for children with myopia. Everyone is invited to become a member of the collective. By joining, you pledge to act in slowing childhood myopia progression. Membership includes regular updates and information about the collective's efforts, access to educational opportunities and resources, and insights from the ambassador optometrists who advocate for community policy and changes supporting the collective's mission. Click the link in the show notes to join the collective today. We've been partnering with EssilorLuxottica 360 for a while now, and it helps us in 3 areas. First, they use social media campaigns to highlight products that we believe in and prescribe to our patients, and they deliver those patients back to our practice. Second, EssilorLuxottica 360 enhances our patient experience through staff training tools that help us simplify and streamline the way we communicate about our products and services. Lastly, but for my practice most importantly, it helps us make good business decisions related to our optical offerings. We will systematically and objectively analyze what our patients are purchasing and what they like, and removing products that our patients are not really using or not really drawn to. This, along with additional rebates and immediate savings, helps us continue to deliver high-quality products and services to our patients and keeps our practice resilient. Check out EssilorLuxottica 360 for yourself by visiting EssilorLuxottica360.com. The other things I think about are that again, trying to minimize the gray in all of this is an example might be for glaucoma. So glaucoma suspects, if you look at the list of causes of optic nerve anomalies that might make you more suspicious of a patient who has glaucoma, the list is pretty long. But if something makes you feel uncomfortable, it can be easy to just kind of write it off like, oh, I'll just get an OCT this year, and if it comes back normal, then I'm not going to have a real conversation with the patient about it. But that doesn't really align with what our clinical practice guidelines say, and so we can kind of be lax in our ability to say, hey, Mr. Smith, one of the things, great news, I've got a new prescription for you, but one of the things that concerns me is your optic nerves are asymmetric. And based on our clinical practice guidelines, this amount of asymmetry puts you at greater risk for developing glaucoma. So we need to dive deeper into that, and I want to see you back in a month to evaluate you. And that evaluation, I mean, you don't have to tell this to the patient right away, but you can, if they ask. That evaluation is going to include visual fields, and it's going to include gonioscopy, and it's going to include an optic nerve OCT. And I'm going to thoroughly evaluate your risk for glaucoma, as opposed to, I feel a little uncomfortable with asymmetry. I'm going to get an OCT because I've purchased the technology, but then when the OCT comes back all normal or all green, and there's plenty of lectures on green disease, and there's plenty of lectures on red normal, then we can feel comforted. But that patient next year is still going to have that same risk, if not worse, more risk from that asymmetry. And our guidelines don't say just do an OCT. So the point here is, if I look at all of those things within the optic nerve that might make a patient more risky, one may not make me feel all that uncomfortable. Two of those things might make me feel more uncomfortable. And so, again, putting down on paper what the characteristics of the optic nerve are, you going to draw a line in the sand where when you see that, you're going to try to minimize the gray, right? You still have to be a doctor. You still have to give your own clinical judgment. But comprehensive exams are so challenging because we have so much breadth of information we need to evaluate the patient for, that if we don't try to define what that comprehensive exam is looking for, and when something is abnormal, we actually take a step back and say, this is abnormal, this does not fall in line with our normals, which means that we've got to evaluate this patient more. And the whole idea then is that if we do that, we will have more confidence in our conversations with the patient. The patient will perceive the importance and the critical nature of what you're finding and why you need to, it's in their best interest to evaluate that. And long term, those patients, when you follow them and you find glaucoma early, even if this patient was normal and you follow a specific protocol and you've drawn those lines in the sand, the likelihood that you're going to miss patients that are walking around with glaucoma that you didn't identify is going to be minimized. So you're absolutely helping your patient population. And you can be confident you'll sleep much better at night because you've minimized the gray. So that's step 2. So we think about which questions and tests we're going to use on follow-up in step 2. So we think about triggers, right? So we talked about intake triggers on questionnaires, risk factor triggers or examination triggers on our evaluation. And then we think about building out, okay, well, what are those things I'm going to look at during the comprehensive exam? And then when am I likely going to follow up with that patient based on that specific condition? And then we kind of build deeper what that follow-up might look like. So on average, it doesn't mean you have to follow this for every single patient, but I like to have people think about 90% of the cases that you have that are glaucoma suspects. What are you going to do for 90% of them, right? Deviate for, you're going to have to deviate for 10% of them, but in your mind, what would be the ideal thing you'd want to do for 90% of those patients that when you pull the slit lamp away, you're concerned about glaucoma? Are you going to see them at 1 month? Likely. Are you going to see them at 6 months? Likely. Are you going to see them, every year? If they're going to see them every year, how are you going to integrate all of those other tests that our clinical practice guidelines want us to do or recommend that we do with their comprehensive exam while you're already trying to address their refractive needs and maybe their dry eye needs? I mean, how are you going to build that out? So you have to do that on purpose for your practice in a way that works for your practice, not the way that it works for my practice. And then you got to think about like whose responsibilities are what responsibilities are my team members going to have? So my staff, what are they going to do in all of this process? And then you also have to think about what's the doctor going to do? What's critical when the doctor pulls the slit lamp away? What are the words that he's going to use or she's going to use to convey the importance of the message? And a lot of this, and we'll talk about this in a future episode, but a lot of this might be just purely related to the words I use have to be impactful for you. It's important that I remove myself from the equation. And so what are my responsibilities? How do I communicate with the patient to inform them about what's in their best interest? And how do I keep myself and my opinions and my uncertainties out of that equation? And so we'll talk about that more, but that's all part of this whole process of why it's super important to be aware of what you're actually looking for during the comprehensive exam that's going to make you more suspicious. And when you feel uncomfortable, how are you going to handle that discomfort? So I hope that was helpful. If this interests you more, we have a ton of resources on iCode Education. We call this the Comprehensive Optometry Simplified program. And really, we found that following these steps that I'm going to cover over the next few weeks, we found that following those steps, you can rinse and repeat for any single disease state, even any single portion of your practice that you want to refine. So contact lenses, we've had clients that have used it for their contact lens annual supplies. We've had clients that have used it for their second pair spectacle lenses. But often we use it, and I like to use it when we think about just chronic disease management in a comprehensive care practice. That is one of the most challenging things that our profession encounters. And if we don't get a handle on it, we've talked about the data before, then it may pass us by. And so I'm concerned about that. So our whole goal is to try to help practices integrate the complexities and the nuances of chronic eye disease, including billing and coding, but not limited to billing and coding, into their practice primarily so they can continue to serve their patients to the best of their knowledge, education, and training, and then receive the benefit for their practice secondarily. So I hope this was helpful. Thanks a lot for tuning in. Like and subscribe. We really appreciate our listeners and those people that reach out to us with comments. And if you have any comments, if you want to talk about something that you've done in your practice that has really helped build a pillar, especially the things that you can't turn away from, drop a comment in the comment section, send us an email, reach out to us. I'd love to know what you're doing. Thanks a lot. I'll see you guys on the next one. Hey, if you enjoyed this episode, make sure to subscribe to us on Apple Podcasts and our YouTube channel, both linked in the show notes. Now, here's something exciting. We're giving away a 1-year subscription to Comprehensive Optometry Simplified. All you have to do is leave us a review on Apple Podcasts, take a screenshot, and email it to me at questions@icodeeducation.com. We'll put that in the show notes as well. We'll be selecting a winner on December 15th, so don't miss your chance to get access to this valuable resource. Thanks again for listening. I can't wait to see your reviews.